So let's talk about body contouring. I do have to say that many treatments are, I wouldn't say ineffective, but the effectivity or the efficacy is very mild. But talking about body contouring and it's everything below the face, this is really rising up. There are some clinics that I know in Israel and worldwide that just treat body indications. So this is the main focus. I think in this era, when we hyper aware of how we look, we have the Zoom, we're having the constant photographing. You can see here, even in the Alma Academy, there is an area which is dedicated for taking pictures. So we see ourselves. There is a mirror in front of ourselves nearly 24/7. And I think this is kind of an era of the unacceptance of imperfection. Kim Kardashian started it years ago, and she started from X. She is here somewhere. Y, it may be not the same person, but the ability to change our look, to do something with I would say, pathologies which disturb us, change our field. And this is the reason when we talk about the body contouring marketing, you can see every year there is an increase, especially with the non-surgical segment. This is from 2020, but the numbers didn't change. If we talk about the non-surgical procedures, people would like to remove fat. Where from? From the jowls, from the submentum, from the abdomen. They want to change I would say, the body contour by either removing or replacing this fat compartment. So what do they want? While talking about fat, it's not just fat reduction. To some area, especially the Brazilian butt, for example, we want to add volume. But it's not just the fat. You have to look at the skin, so the skin imperfection, cellulite, shape irregularity, of course, muscle toning, and in general, nothing would surprise me. People come and ask for crazy, I would say, areas of treatment, and we have to decide whether we treat or we do not treat, whether we agree with the indication. However, if it pleases the patient and it improves quality of life, why not? So where can we treat? If we talk about fat, the areas or the main areas are the submental area and the interface between the face and the neck. We talk about the abdomen, the love handles. In women's, it's the area below the bra. We talk about the butt. We talk about the thighs. But again, every area is a candidate. I do have to say, and it's true for surgery as well, if you are not stable, so if the weight is changing every second week, it's very difficult to really, it's like a patient who comes with pigmentation, if he or she goes and, they're getting suntan, this is really impossible to treat. So it's the same for body indication. We talk about stable patient, and I'm talking about stability of different aspects. But always when I talk to my patient, I mention diet, I mentioned physical exercise. Sometimes I'm telling them, look, it's a waste of my time. You should go through a surgery. And nowadays, we prescribe medication. I'm sure you heard of the Ozempic and some other medication which can take it one step forward. While talking about the non-surgical interventions, it's always about the energy-based devices, but injectables as well. So you have to think in mind, and we are going to see great cases in a second, always on three main components. First, fat. If you have fat, you have to remove fat. So, for example, in one of the, it wasn't in Alma Academy, one of the Alma Academies, it was another conference, and someone asked me about laser, an external laser for the fat compartment. So as far as I know, lasers usually reach, I'm talking about the external, not with the optic fiber, 1,500 micron, 1,800 micron. So we don't really reach fat. So if you want to really treat the fat compartment, you have to use either mechanically to really take it out, or enzymatically. Kybella got a bad name, but there are many lipolytic agents in the market, and many companies now develop lipolytic agents, or to do it with the aid of the device. You're going to see the experience with the Slim Lipo, so the devices of Alma, but there are several devices in the market which will kind of dissolve the fat and will actually from beneath or from inside will tighten the skin. The skin, this is the second component. Sometimes I see patients who went just through mechanical liposuction. It doesn't improve the skin, so the skin is redundant. So if you want to address the body, fat is one, but you have to think about skin. Skin you can use with different devices. We know how to treat skins, lasers, radiofrequencies, ultrasound. The list is very long. However, in the last 10 years, we understood that muscle is part of the game. And if you want to have, even if you're very slim with no fat and very thin skin, if you have diastasis recti, or if you have very weak muscles, it won't look good, so you have to tighten the muscles, and there are several devices in the market. So always think about 1, 2, 3. So as everything in our field, it started as monotherapy, but nowadays we all know that in order to really augment the result and achieve good result, you have to combine between modalities while addressing fat, skin, and muscle. So for example, just like a hint, if I have a lady after, let's say, 3 pregnancies, she's very slim. She has just this crepey skin. I don't have to treat the fat. There is no fat. But the skin has to be treated and the muscle, as compared to, let's say, a more chubby lady or man, in which there is a fat compartment but very good skin quality. In this case, the fat compartment as well as the muscle, they both has to be addressed. So we have great speakers that I'm going to go, I would invite them. So Pablo Naranjo, you met him already. He has an enormous experience in body contouring, and I always like to listen to him. So Pablo, please come to the stage. Fatima, I heard this is a thing. She was moderating the Alma Academy of Latam. She did a better job. She was great. And she has really great experience. You will see her cases. And Pina Panchel, you remember Pina Panchel. And the only one that you do not know is my friend, Dr. Ines Werner, who is a board-certified dermatologist. She's a professor, and she's really many years in the market. And I think it skipped, but I learned about you that you speak 6 languages. Ooh la la! But she speaks the language of love.
I can
This is the most important. All right. So we're going to start. Pablo, okay. You're the expert of body, in my opinion, so your case.
Okay. So let's go to the first patient, woman, 46 years old, skin type 3, wanted some improvement in the buttock area. What to offer her? If you see, it's not just fat, it's not fat, it's laxity. It's a mixture about an excess of fat, but a huge excess of laxity. So she doesn't want any kind of surgery. She doesn't want any kind of semi-surgical, like the laser lipolysis. She wanted just something external. So we decided to apply the premix. This is the reason why we bought the premix, those kind of patients. Those kinds of patients who have excess of volume, but a huge excess of tissue. So which parameters do we apply? So I will try to explain, because we have done 4 sessions spared by 2 weeks. When we apply radiofrequency, we can apply just a weekly treatment, but personally with ultrasound, I prefer to wait 2 weeks. So can you put, please, the parameters? Because I will explain. So you have a toy when you have a Primix, and you need to know that it's something really interesting to play with it. In lasers, we see pulse duration, energy, ablative, non-ablative in hybrid. Here in Primix, it's very similar. Do we want to tighten the skin, or do we want to destroy adipocyte? Adipocytoclasia has been proved with cryolipolysis, with injection of lipolytic solution, but also with focused ultrasound. Remember, those three are the three big FDA-approved technologies to do disruption of the adipocyte, to break the membranes of the adipocyte. So when we apply the ultrawave, please, can you put the parameters? So we are applying an ultrasound who is able to break membranes. So in the protocol, we decided to start doing disruption of the adipocyte, so to break cells, to do a treatment on the fat, but immediately the second session is a treatment on the laxity. The third session is like the first. We treat again the fat, and the fourth is like the second. We treat again the laxity. The idea is I reduce volume, I stretch the tissue. I reduce volume, I stretch the tissue. The pictures you have seen who are quite good are just 4 sessions repeated by 4 weeks. The most important thing is to do a preheating. When we apply radiofrequency, we are working with electrical impedance of the tissue, resistance. When we apply ultrasound, we are playing with acoustic impedance, and they are very, very similar. So it's very interesting to do a preheating before doing the real treatment. So in the first treatment, we decided to break adipocyte. This is the reason why we put high energy on the ultrasound, long time, 15 minutes, and we apply 20 in the ultrasound means it's continuous emission. We don't have thermal effect. It's pure mechanical. And this is the reason for this device, to break adipocytes. Totally different to the second and fourth session, where we put 0.20. We don't want the mechanical effect of the ultrasound. We want the deep effect of the ultrasound to create heat. Because with the ultrasound, you can create more heat or more mechanical effect, more thermal or more mechanical. 2020 is pure mechanical, breaking cells. 0.20 is thermal effect. So the idea is first and third session, we preheat the tissue with the radiofrequency. We don't need to be very aggressive. We go deep and we preheat. And in that way, we change the acoustic impedance and the electrical impedance of the tissue. And in the second pass, on the first and third session, we do the ultrasound 2020 to break maximum 8 watts, 15 minutes. Second and fourth session, just the opposite. We want to stretch. If we want to stretch, we preheat with the ultrasound, but not anymore 2020, 0.20, before the radiofrequency, who is going to create the stretching. So it's just the opposite. Session 1 and 3 are opposite to session 2 and 4. In that case, we create adipocytoclasia, and we stretch the tissue. So the treatment is really non-painful. We are talking about treatments who takes 20 minutes, something like that, 5 plus 15, 20 minutes. They are non-painful. There is not discomfort. The patient can come, continue their regular life, and they really work. Evidently, devices cannot do 100% of the work. When we do adipocytoclasia, we need to tell the patient that energy is not destroyed, it's transformed. So free fatty acids are going to be inside of a bus with the albumin, go through the lymphatic drainage and through the vascular system, and your muscles need to consume it. So we don't tell the patient, do exercise, but we tell them, if you want to help me to reduce the number of sessions, you should consume this energy. 2 ways to do it: you close your mouth or you do some exercise. Don't say that because it's quite aggressive. Say, do you normally do exercise? No, I never do exercise. Okay, so please stop 1 block before your walk, stop the car and walk just a bit every day. And if they do exercise, tell them to do exercise immediately. Do you go to the gym? Yes, of course, twice per week. Go today, go tomorrow. Don't wait 3 days to go. We need to consume this energy.
I have one question. What was the complaint, the exact complaint of the patient? What she wanted to achieve? So I understood what you did, but what she told you?
She told me, I want to go to the beach and put some how do you call it? Some bikinis.
Bikini.
And I have 46 years old. My husband is quite good looking, and I don't feel that I'm good looking.
All right.
Oh, I just want to go to the beach.
So if this was the description, now maybe come to us. Maybe let's open it, because, all right, for sure, we see the result, we see the parameter. Let's talk about butt, okay? So she wants to go with bikini. We want to augment the butt. What what would you offer her? What are the possibilities? Okay, that was one approach.
Like a biostimulator, maybe, in
Oh,
addition to
all right, so
volume
maybe
and lifting?
biostimulator to what for? What is the
For
reason?
one for her skin, but also for volume and lifting.
Okay. Shaping. So when I saw the picture, you know, when I went over the cases, I said like, I would have, maybe it's my taste, okay, but it should be more like, all right, so shape, how do you actually create shape?
You can use body stimulator for body shaping, and you can use different amount of in different parts of the back. So you can make like a heart shape it.
So I'm curious, if you mentioned a biostimulator, do you use the same reconstitution? So what is your reconstitution for, let's say, contouring as compared to skin improving?
Yeah, if you talk about, thank you. If you talk about polylactic acid, for skin smooth, I use like a very high dilution. So I use in 20 millimeters. But if I want to increase volume, I will use in 10
Yeah,
millimeters.
same. Same.
Yeah.
Do you use hyaluronic acid-based filler for butt augmentation?
I don't. It takes a lot to get to that desired shape, so I prefer the
Ines,
biostimulator.
do you?
No, but I do use a lot of PLA, and I have been using also calcium hydroxyapatite. And also in the same way like you, if I need volume, it will be the regular dilution, and if I want to biostimulate, it will be hyper diluted, what we call, and for every filler, it's their recommendations of the company. And what I also do, I combine the biostimulators with energy, and I love that. And I do it in the same session. So there is no problem doing it in the same session. So for instance, in this case, I would do first, I can do first the Alma Primax, the Ultrawave Unibody, and then even in the same session, I would immediately add the volume, and it works amazing together.
So we talk about the shape. We actually didn't cover it because this is a major topic. We didn't cover fat, which of course it's a possibility, fat transfer. I do AJ. There is, you have AJ for the body, which can really augment the result. Of course, it's temporarily, but it's a good result. I usually use biostimulator for the skin. But let's talk about the second problem. So the skin irregularity and cellulite. So how do you address cellulite in your practice?
It's a difficult question. I think everybody, well, it's difficult, but I think we really need to combine. And for me, cellulite is, again, a combination of technology and injectables, because it's a multifactorial problem and very, very difficult to treat, and also there is a lot of recurrence. So if you treat, if you treat, they will come back a year later, it recurs. So for me, it will be mainly subcision when I'm doing the biostimulator. So I'm actually subsiding and injecting mostly.
Can you elaborate which cannula? What do you do?
Yeah, I can use a 23, actually the 23G cannula. I don't use a very thick cannula. Sometimes I use the Nocor needle to subside. I don't know if you have that also. And then I inject, and I can use, and I also like a lot the Ultrawave and Unibody. And why? Especially this technology that we have on the Primax, because what Pablo said, it actually breaks the fat cells, but it also breaks the septa, because the ultrasound that we are using is a low frequency ultrasound. And because it's a low frequency ultrasound, the effect on tissue is mechanical. So we're actually introducing some kind of shock waves into the tissue. And this breakage breaks not only the adipocytes, but also somehow, most probably, parts of the septa, because the subcutaneous fat is composed not only of fat, it's also a lot of connective tissue. And to improve cellulite, we have to break down the connective tissue, these bands that are connecting down, and to stimulate new production of connective tissue, and of course the fat will...
Again, to summarize, while talking about cellulite, you know, more women, less men, because of the orientation of the septa. We do know that it's that you have to kind of subsize chemically or mechanically the septum. We're not going to get into details, but in the past, maybe there were like some device, I can mention, Selfina was very aggressive. Now I think there is something in the States which is called Aveli to really cut it. I use a cannula as well. I'm less, I'm very aggressive with my patient. I use usually the 16 gauge cannula.
16 gauge?
Yeah, and I really subsize it and I have really good results. Or the knocker needle
You're a man.
immediately.
Yeah. We are more gentle, the women.
It's instead of going to the gym.
After the gym.
And I have usually either Radius or Sculptra, and then on top of it, we use the devices that you mentioned. But again, I think so whenever I see such patient, I really go over what disturbs you, okay? The descent, the shape, the irregularity, the cellulite, because especially in these patients, it's very difficult. One maybe tip that I can give you, or it's, again, from my experience, especially for body indications, it's right for every aesthetic indication. Scales. Use scales with your patient. So let's say for body indication or cellulite, those XL, there is a scale, there are many scales, but there is scales for cellulite. So usually we take a picture of the patient. The patient looks at her photo and we ask her, how do you score yourself? Okay? And then she, for example, said 3. I'm always telling them we can improve usually with non-surgical around 1 point, not more. And then when they come after 6 months, after several treatments, I don't see anything. Again, we take photo. Can you score yourself? And the scaling is in the room. So she looks at her photos and the picture said, I'm 2. So I said, you see, there is 1 point reduction. It really assists body. If you want to really deal with body, you need to have good camera, good documentation, and use scales. And in the sake of time, we have to carry on.
Yeah.
So Fatima, the second case is yours.
Yeah. Okay, we'll talk here. Oh, this is a female, 26 years old, skin phototype as 4, and she just gave birth 6 months ago. So she came very stressed for the laxity of the skin and the stria. And the stria was more white than reddish. It's not so normal for 6 months, but that's what we have. And we decided to do the Pixel RF. And we perform 4 sessions, 1 each month. Can you put that out? With the microplasma technology that you can have with your Accent Prime, your Accent Prime X, or the Opus one. And we use 2 tips. The one, I put it Ice Pick tip. They also name it Focus tip, which is a static tip. And you are like doing stacks over the stria.
So you choose the very narrow roller, right? Or the one,
No.
The
stack tip. The stack tip.
This is the second
The
step.
second tip.
And the first one?
The first one is the atrophic, which is the very big one, with 6 rows.
Okay.
But I perform first the Ice Pick tip and do like lines with the stacks over the wider stria. And after that, I perform in a crisscross way the atrophic tip, several paces. Like in one row and in another doing crisscross things. And it's a very, very, very fast treatment. You perform the treatment in all the abdomen like in 5 minutes, maybe 6. You can use the open channels you have on skin. So I apply collagenase there.
Which company?
PB serum.
Okay.
And lead therapy. An occlusion?
The large, the medium, the high, which of the product?
No.
You know, again, no financial interest. Okay, because if you mention it,
But that time, we have just the isolate ones.
Okay.
You have 3 different
Yeah, yeah, yeah.
bottles.
Okay.
And I use just
Not
the
the
collagenous.
combination.
Yeah,
All
not the
right.
combination one.
Okay.
The combination one comes with hyaluronic acid and, no.
No, not hyaluronic acid, liase and lipase. Okay.
Yeah.
Yeah. All right.
So
Very
that's
good
the
results.
treatment.
Very good results. So
Yeah, you can
first,
zoom it.
the ice pick over the area, and then the microplasma, and the lead therapy. Good result. Very good result.
amazing.
Again,
Not
I
only on,
encourage-
over the stria, but on the laxity of skin, you know.
Okay. And you wrote lead therapy. How you perform it? What is your protocol? Is it an office procedure
Yeah.
or which wavelength?
Red ones.
Okay.
Yeah, I have the red and the yellow one. The yellow one is more anti-inflammatory. I use both, but here I use like the red one because, you know, like more neocollagenogenesis. So I like this more, and I use that time to let the collagenase get in. So it's like a time,
Absorption,
for the absorption time, it's like 5, 10 minutes, maybe 15 minutes, and after that, the patient can go to his home.
Yeah. Really good result. Okay. So from one stria to another stria, Dr. Ines
Yeah.
Werner.
So this is quite, maybe even one of the most severe cases that we've had with stria. It's a 26-year-old female from Ethiopian origin. And actually, she came with the most pronounced stria. It was not exactly clear why it happened so fast and what, but anyway, she was healthy. So we decided to treat her with Primex, actually the microplasma technology. Also, we have it on the Opus or the Primex. And we've used a little bit of different parameters than Fatima, but for me, this is my go-to treatment when we have stria and large areas on the body. My go-to will be the roller and the microplasma technology by Alma. And the reason is that it's easy to do. It's not painful to the patient because other technologies can be very, very painful and patients cannot tolerate when it's painful and you'd have to cover large areas. Also, it's fast, so it goes very, very fast. You can treat a whole body in 20 minutes, maybe half an hour is max to cover all the areas. And I think that the results are amazing, in my opinion, because it's really, again, stria is a very, very difficult problem to treat. And we actually just used this technology. We didn't add anything on top, just something to, you know, for the skin to recover. And we've used actually the atrophic tip, the 6 rows, so it's the roller that there is, and I love the roller. It's my first go-to for many, many indications. We didn't use such high powers. We don't even, many times, we don't even give our patients like topical anesthetic. Sometimes we do, and they just come, the technician does the treatment at the level that the patient can tolerate, at that energy level. And then we do many passes. So you have to, this was 4 passes, but sometimes it can be also 6 or 10. It can be a lot of passes on the same area. First we go thermal and then we go ablative. So first we get some coagulation in the dermis, like a little bit in the depth, and then we go more superficial. So, and this is already after 3 treatments, and she will come for more treatment. So it's actually quite amazing. I'm really, really surprised with the results.
I have a question for both of you, Ines and Fatima. You know, we differentiate between red stretch mark and white stretch mark. Here it's kind of in between. The last one was linea alba. It was stria alba. So how do you change your protocol if you have let's say, immature, very reddish stretch mark, do you treat differently?
Theoretically, you should. Practically, I think it doesn't really matter, because I was using for many years also, and I mean, you could do an IPL first, and I was doing that for many years. But lately, I think it does, in my opinion, it doesn't really matter, because somehow the microplasma and the fractional RF technology introduces some wound healing mechanisms that actually influence also the vessels, and it goes very fast. So in this case, this is like an earlier stage, like it's still red, so you could have more effect. Of course, we're more effective if it's an earlier stage. Of course, when it's already linea alba, we are less successful than here.
Yeah.
So, but I think we have to initiate treatment as early as possible, and that's an important point to tell our patients. And for me, I think in practice, but of course I don't have a study, I think it doesn't really matter.
Dima,
finally.
any other?
I think the same as Ines. Oh, sorry. I think the same as Ines. I know that you can try treat this with IPL or with dye laser or whatever, but I do prefer the microplasma technology because it tightens skin.
Yes.
So that's what we are looking for. They are scarce, and we see better results. I don't know. I didn't perform a study, and it's very fast. And I don't know. I prefer it.
Personally, I will add in the same session an IVL treatment.
Yes.
It's not risky. You can do 2 passes, and in the same treatment, you do the microplasma.
What are your parameters if you use the DIPL?
We are applying like 10, 12 joules and 8 to 10 milliseconds. Okay. So we do 1 pass crisscross, and then we do the 6, 10 passes with the...
But then, you know,
I think I do
this
the
is a dark
same,
skin type.
but again, I'm not sure.
But remember, it's a dark skin type.
Yeah, yeah.
So, and it's cumbersome for your technician too, because she has huge areas. So for me, it's really like, take this technology, take this roller of the microplasma, go over the area. It's fast, it's efficient, and you don't risk anything. You know, I think with the IPL, with high skin types, you still have a little bit of risk.
And you're not raising the cost of the treatment.
Yeah, yeah.
You know, like it's cheaper
Another question,
and
do
faster.
you ever consider, it's for all of you, Dr. Pangela, do you ever consider to inject biostimulator
Yes.
into the stria?
Yes.
Yeah. And what is the order? Which biostimulator?
So, I mean, I just hyperdilute like Sculptra, and I rub it on top, so I don't
So
necessarily
you rub it
inject
topically?
on top. Yeah,
Okay.
I hyperdilate.
Some of you inject?
I inject
yeah.
a lot of biostimulators too. And what is interesting that I inject first the biostimulator, then I go over with the microplasma. But what is interesting is that when you go to congresses, they tell you you need 4 vials of the biostimulator, 10 vials of biostimulator. If you use a biostimulator together with technology, you need much less quantities of the biostimulator. So even just 1 vial of a biostimulator can be enough to get a very, very nice
Maybe I'll
clinical
summarize.
result.
During the SCAR conference in Berlin 2 months ago, we had a great session of like the Fast and Furious. So every speakers, we had like 12 speakers, and everyone shared his experience, like his best approach for stria. So it's like you heard Jill Whitebell from the States and Warapong from Bangkok. It was interesting to summarize the following. First, people as a first step use some biostimulator in a very low or high reconstitution, low concentration. This is one. The second, people use different energy-based devices. The Asians really like the Pico second fractional laser for this indication. They go with a very like high fluence, like they really love it. I tried it in my hand, I didn't see any result, but again, maybe it's again different skin. The Americans, they really like to go with lasers. And the European, again, this is really, I'm trying to simplify, They really like radiofrequency. And probably it was El Domyati from Egypt. He was showing many results with just microneedling. So injectable biostimulator, then some energy-based device or microneedling, and then I would say the add-on. So for example, Professor Mirette Addersdal from Denmark, she added tretinoin 0.5% immediately post-treatment, and she showed, actually she published, it was published just 3 weeks ago, but she showed it before, so good result. And the X factor, it's, I would say, the creativity of the physician. So I saw people who do LED, and I saw people who at home prescribe some formulation, mainly the combination of tretinoin and glycolic acid. But to summarize, Stria, complicated. We cannot really solve it. We can improve it. It's probably injectable of biostimulator, energy-based devices. You saw some great result with the Opus or the microplasma, the different tips, and you saw different combination. And again, many roads to Rome. And I think for the sake of time, let's go to the the last one, I think. It's yours, Dr. Panchel.
Yeah, so this is a 63-year-old female, type 3 skin of like Cuban descent. She obviously had 2 pregnancies earlier in life, and she has been working out, goes to the gym about 3 to 4 times every week, and she's fine with her weight. She's fine with everything except the laxity of the skin. That is what bothered her. Nothing with weight. She did not want liposuction, nothing like that. It was really just the laxity. She came in with realistic expectations. You know, she said, I just want to feel a little bit more comfortable when I go to the beach. So I, at that time, tried our Opus laser. That's the one we tried.
So before you show the result, which I couldn't sleep at night.
I know.
Seeing the result. I'm wondering, you guys, if it was your patient, what would you do? Ines?
For me, I think I would use biostimulators because I think her main issue is laxity. So it would be a combination. And then, so biostimulators together with the Opus, Primax, fractional microplasma on top, several treatments. And I think she will need several treatments and not quite a quantity of vials, for instance, if it will be PLLA or calcium hydroxide, but she will need some, because I think a huge part of the problem is her saggy skin and that her skin is so thin. Mm-hmm. It's a problem.
Fatima?
The first thing I will recommend this patient, it will be surgery. But if she decide, and if she comes to me, it's because she decide not to go to a surgery. So there, I will offer her the same thing you're offering, like biostimulators and microplasma technology, you know, our atrophic Opus treatment. And I will say that she will have mild to moderate results.
Lower is a good point, lower expectation.
With a high number of sessions.
Mm-hmm. My dear Pablo?
In my case, I will treat both deep and surface. Deep, I will combine ultrasound, radiofrequency, and biostimulators. And when we apply the technology in 360 degrees, not local, and then I will treat superficially with microplasma, all the texture and strias.
All right,
beautiful.
So talented Dr. Panchel,
Wow.
what have you done?
Amazing results.
So, I mean, some of the same stuff that we discussed.
First, I'm making an appointment.
Yes.
All of us.
You know, at the consultation, we discussed some of the same things, potentially using a biostimulator. I don't have the Accent Prime in my clinic, so I didn't have that as an option. We did discuss potentially going for a surgical procedure instead, but she had low expectations. She She was actually the aunt of one of my employees and was just willing to try it and was happy with whatever improvement she had. So obviously, I did not promise this level of improvement. We were all shocked. This is actually without a biostimulator or anything. It's purely just mycoplasma. I did 3 treatments, about 6 to 8 weeks apart. And again, we started at a low energy just because of the body. Plasma level was a little higher at 40%. We started with 3 passes. She actually had pretty good improvement even just after the first treatment, like noticeable improvement even after just the first treatment. So healing was fine, downtime was fine, so we increased her power on the second treatment, and I also increased the number of passes. She tolerated it fine. And then we stuck to the similar settings in the, well, actually, no, we went up, sorry, to 40 watts and then 60%, and then 4 passes again. Again, I don't think this is necessarily the norm with body skin laxity. It's very hard to treat, but she did well. In hindsight, I wish I maybe addressed her stria a little bit, because now that is what's bothering me. It doesn't bother her, but that's what bothers me. We did discuss the stretch marks at her consult, but I don't even think she could see them with the laxity at that point, so they didn't bother her. Maybe I could have used some topical bromodoprost, to help with the pigment there, but I don't think it's as noticeable.
Very dramatic.
Yeah, dramatic.
we are,
amazing. Wow. Actually, it's very interesting how patients improve after these technologies. So there's like a mean improvement that most patients will have, but some patients, they actually get,
Like an outlier.
Yes.
Right.
You do just one treatment and they come back to you after one treatment. You say, oh my God,
Right.
how could this?
But it's like, I think it's like with time, for example, we published the polylactic acid changes in the dermatological surgery. And we saw that, there are several changes, but in the end, you have patients where they like the high performance, I call them. You have the ones who are very low, 0 to low performance.
Yes.
And most of them are average. And this is kind of a message. I'm always telling the patient, look, it's like a test. I do not know if you're going to fail or you're going to succeed. I can tell you from my experience that it's like a Gauss curve. So the minority here, these are the results. The minority here, the results are very subtle, but most of the results are average. And it's easier to delegate and to not to promise too much. We have to carry on to the question. We have a question for you, Dr. Fatima. Did you perform just one pass with the roller or crisscross? This is Ariana asking.
No, a crisscross technique and as much passes as the patient tolerate. So maybe start with
Like tick, 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 tick.
just one pass.
All right.
That's one pass, and you can do it like 4. In the next session, you can do it like 6, 10, because I think that the more passes you go, you make,
painful?
it's better. Yeah, it starts to annoy very much, so you have to do it quickly.
All right, so multiple passes. This is a question for you, Dr. Pablo. What brand of PLLA you used?
I didn't use. Normally I apply, but not in this case, because I wanted to see only the result with the device.
There are several in the markets. I think it's not the place to get in, but of course you have to understand the reconstitution and choose always. It's true for lasers, it's true for injectables. Look always if there are enough studies and enough, I would say, scientific backup for a product that you inject your patient. The question that I ask myself, would I dare to inject the product into my face or body? And if you think you wouldn't dare to inject it into your face or body, do not inject it to your patient. This is a question for Dr. Fatima. What can we do to prevent PAH, especially in stretch mark?
I use before and after glycolic cream with hydroquinone if there is a high skin phototype. And also I use rose hip oil.
Rose hip
Yeah, it's
Immediately after?
no, not immediately after. Like after 2 or 3 days, when the crusts are going over.
I will check it. There is a branded formulation or something that you...
No, I use like the most natural ones. You know, like organic ones.
Okay.
It helps to smooth the skin. It's regenerative also, and patients love it.
Okay.
So in my experience, we apply tranexamic acid, 500 milligrams, 250 morning, 250 evening. It's cheap, and we maintain doing 1 week. We can also put it
For how long?
next week after treatment. So for 1 week is enough.
For just 1 week?
1 week after each one of the treatments, if they are not high phototypes. If they are very high phototypes, we maintain
But
minimum
Pablo,
3.
there are no publications to support it. I mean, I love you, but it's like most publications are controversial. The ones that I know do not support it. And for 1 week, I don't know.
When they are
Okay.
high phototype, the publications say 3 months, no more than 4 months. And this is the real publication. And when we do CO2, when we apply continuous 3-4 weeks,
I encourage you to do split stress study. One.
Okay.
All right, because I don't know. It's like there are no publications. We'll try to be scientific. We apply steroids following treatment. I think it's a problem because on the other end it will suppress. But we do it. We use hydroquinone the same way, and I think there is a way for the red light. There is. I see some tendency. Again, it's not proven, but they have to repeat it twice weekly, so there are less PIH. But this is actually a good question because we see it. Again, Fatima, this is for you. What was the downtime of your patient? This is Christina Cocu.
Yeah, the patient will have a small crust for maybe 5 days, more or less, and you have to hydrate the skin, moisturize the skin, so the crust will go away. I just ask her to come with a very comfortable clothes for that day. That's only. And avoid sun exposure.
Yeah.
During all the treatment. For me, it's better for all the treatment.
It's a question for all of us. How do you perform the treatment? Which topical anesthesia do you use before the opus or the mycoplasma? What do you apply?
Personally, and many times I don't apply anything. And sometimes if I want to go deeper, for instance, for acne scars, where you want to go deep, I will use a topical anesthetic, but many times just for rejuvenation or...
How many of you have Zimmer or any cooling device in their clinic? Raise your hand. So, there are several devices which are not, I would say maybe there is no return of invest, okay? One of them is a camera, okay? We all probably buy expensive camera because we want to kind of have the data very solid and to follow our patients. But for example, Zimmer or Zimmer-like devices, I think especially nowadays, this is kind of a must, and that's what we do. So we do the microneedling, RF, and the CO2, and it's a must. Okay, so it's like if you treat, in the end it's painful, especially if you do the crisscross several times. It's a Zimmer. You can prescribe some oral paracetamol or Optalgin, or sometimes we prescribe some opioid as well. In the States, for example, I have a patient who came back from the States. I was shocked. You know what they put? They started, maybe, I don't know, maybe you have it in your country. It doesn't exist in Israel. They use sublingual ketamine, okay, in many clinics for such procedures. But the pain component, it has to be addressed. We use the BLT in our clinic, but topical anesthesia as well as cooling, this is probably a must.
But in my opinion, I think the microplasma technology, it's not so painful. And I think that's at certain energies, of course. If you want to be very, very high, it will be painful. And I think that's a very good, that's a great profit of this technology when you compare it to other microneedling RF technologies, which can be very, very painful to a level unbearable. So
but in the thermal, you have 2 passes of thermal and 2 passes of ablative. So the thermal can be tolerated, but the ablative, it's painful.
So personally, we apply, it was a very interesting PhD in University of Oporto 10 years ago, talking about anesthesia, topical anesthesia and CO2. And the conclusion of this PhD was 6% lidocaine, 6% tetracaine, 6% lidocaine, lidoprilo tetra, 6% is a very strong compound. It's not risky if the small is area small, and it works extremely well. The patient doesn't feel nothing.
Perfect. A question for Ines. What post-treatment? What is your recommendation post-treatment?
Yeah, so I give my patients two things. I tell them, first of all, that it will be a little bit sensitive for a day or two. Their skin's going to be sensitive, especially when it's the body and when they shower too. And I give them two things. One, I give them a combination of an antibiotic with a light steroid, just in case, if it's very red or inflamed. I tell them, I give them a prescription, don't use it. If you need it, if you have a lot of inflammation, use it, because if there is a lot of inflammation, there is a chance for a PAH. And the second thing that I give mainly to the dark skin patients, I give them a very small quantity of a Kligman preparation to start using twice a week, just the next week after the scabs are gone. So they will use it twice or 3 times a week to prevent PAH, only for the dark-skinned ones. And of course, not, prevent sun exposure and an SPF naturally.
Pina, another question for you. For your patient, would you recommend EMS product, EMS technology?
During my consultation, I did an evaluation of her abdominal muscles, and there wasn't that much, it didn't feel like that would help that much, basically.
I offer it to every patient.
Yeah.
I think it's,
Something
in the end,
additional.
I'm 50, will be 51. So in the end, it's not the same, come on. And it's not that we treat 18-year-old patient. So if post-pregnancy a patient is coming, probably she has to strengthen her muscles, so it's for everyone. And I'll ask her the last one because we're out of time. Have you tried epidermal growth factor gel? It's Dr. Dawan. Again, they're different in the market. I have to say that it's, and there are studies regarding fractional radiofrequency and epidermal growth factor, and actually they show that it's better than as compared to just microneedling. I don't know, but again, different companies, different products. Maybe this is not the one. I'm telling you, in this SCARS conference, it wasn't mentioned, and we try to really validate and to go over all possibilities. So thank you so much, the panelists. You really rocked. Okay, rock star.